Good morning. My name is William Brown, or Bill, and some of you know me, and maybe some others not. But anyway, this is part of the InfoHealth program, and this material is being recorded on YouTube, so you can access it at any time, and probably for the next few years. Which brings me to that first slide, because these are footprints of children and teenagers in New Mexico, sometime between 23,000 and 21,000 years ago. That's a long time ago, earlier than we thought. In fact, much earlier than we thought for that area. And the interesting thing here, quite aside from the prints, which always fascinate me, whether they're Neanderthals 100,000 years ago, on the coast of Spain, or in England 200,000 years ago. So they're fascinating. But there's apparently no genetic imprint on any native peoples, current native peoples, for these humans over 20,000 years ago. That's extraordinary. So what happened to them? Are they a ghost group? Whatever. But so let's move on into this today's subject, which is a controversial one. It's about Alzheimer's disease, but more importantly, it's about the controversial new drugs, one in particular, but now two, the anti-amyloid drugs for the treatment of Alzheimer's disease. And this has been a goal for science and neuroscience in particular for at least 3 to 4 decades. And whether we've arrived there or not, well, that's for discussion today. We will see. Well, let's first of all make a few points about dementia. Dementia is a group name, and there are many causes of dementia, of which the most common cause is Alzheimer's disease. But it does bring up the question, given the complexity of dementia, how certain are we about the diagnosis of Alzheimer's disease based on clinical features or laboratory features or both? Dementia has many causes and clinical presentations. And I think the most troublesome, and it may influence these current drugs, is that 2 or more causes of dementia may coexist at the same time. And the 2 common ones are cerebral vascular disease, with dementia related to that, and microvascular disease begins in the late 60s through the 70s, 80s. That's very common, but so is Alzheimer's disease, and the pathologies commonly coexist. And what makes it even more difficult is it may be impossible to sort out the relative importance of these 2 causes, or 3 causes possibly, of dementia in any individual patient. Now, this just lists, I just want to make a point here. It's really not, I don't want to spend a lot of time on it, but there are many causes of dementia, as I mentioned earlier. Some of them are preventable or manageable, and those are the ones in red here. There's no doubt about that the current management of dyslipidemias and hypertension has significantly reduced the risk of stroke. So that's one contributing cause for dementia in later life. Repeated concussions, well, reducing the risk of them and managing them better, but really reducing the number and the risk of concussion. That's important. In later life, blood clots over the surface of the brain may happen, and with even minor bumps of the head. And this can be insidious. The symptoms can develop insidiously and mimic dementia. But with a CT scan or other evidence of a clot in the brain, they're easily fixed neurosurgically, and most patients recover quite well. Drugs can certainly influence cognitive function to our detriment. Normal pressure hydrocephalus, it's certainly not a common cause of dementia, but recognized, very treatable. The ventricles in the brain are dilate because the absorption of cerebrospinal fluid is blocked, and putting in a shunt is a very effective treatment. Well, we can do something about alcohol abuse. B12 deficiency is one deficiency that can certainly lead to dementia. But the important thing is that in the late, middle, and later life, to remember that there are treatable causes and to look for them, and not just jump to Alzheimer's disease or one of the other neurodegenerative diseases. Cerebral vascular disease, well, one of the most common features is diffuse ischemic microvascular changes. That's a common comment or observation by radiologists in looking at MRIs and to a lesser extent CT scans of people in late, middle, and later life. Certainly multiple strokes can sometimes be associated with cognitive impairment, and sometimes a single stroke strategically located can cause significant cognitive problems. I certainly remember my father-in-law who had an ischemic stroke affecting his thalamus on the non-dominant side, and that really impaired his recent memory for several weeks and even months. And there was a significant impairment of his cognitive function more broadly. Whether that could all be related to that single thalamic stroke, we don't know, but certainly possible. Well, the neurodegenerative causes, I've listed them here in order of frequency. So the highest frequency is at the top, Alzheimer's disease, most commonly sporadic, familial, meaning that there are several other members of the family that probably had Alzheimer's disease, and the much rarer, 1 to 5%, autosomal dominantly transmitted Alzheimer's disease, which I'm going to talk more later. Frontotemporal degeneration is the second most common cause, and its clinical features are quite different, or can be quite different from Alzheimer's disease. Parkinson's disease, certainly in the later stages, and less commonly Lewy body dementia, and all the others listed below are much less common, so I'm not going to deal with them. But what about Alzheimer's disease? Where is the pathology? Well, the pathology is widespread, but characteristically, it involves the medial temporal lobe and the parietal and frontal regions. And in the medial temporal lobe, affects regions of the brain, such as the hippocampal area, and other areas that are related to memory and a sense of position or place, so-called grid or place nerve cells. So it's not surprising that pathology involving the medial temporal lobe might disorient patients in time and space and facial recognition. Those are all common early features of Alzheimer's disease. From a pathological point of view, two hallmarks are plaques, neurofibrillary tangles, and I'll show you a couple of pictures those, and the atrophy of some of the associated structures. At a molecular level, Alzheimer's disease is associated with the accumulation of amyloid beta and tau proteins, and but there's some question about the relationship between neurofibrillary tangles and plaques and symptoms. But here are some views of the brain. These are vertical slices of the brain, so you can see that the lateral ventricles here. Here's a normal subject, and this could be somebody with early Alzheimer's disease, somebody with later stage Alzheimer's disease, and the reason for showing these is this is the medial temporal lobe here. Those cells, place cells, the memory, the hippocampal formation, so important for memory. That's where those cells are located, and that's where the pathology. You can see that the atrophy involves those areas, and certainly much more so in a much later stage. But look, the pathology extends well beyond the medial temporal lobe. I mean, just look at the rest of the temporal lobe here. That's atrophy, meaning that the gyri are narrower. There's more space and fluid between the gyri, but that extends to the brain elsewhere. Look up here over the top of the brain and the lateral ventricles here. Look at these are normal lateral ventricles here, and third ventricle here, and much larger lateral ventricles here, probably secondary to losses of nerve cells, nerve fibers originating or going to the neocortex. And so that's the kind of anatomy of the lesions. And here's what they look like. On the left here, these are neurofibrillary tangles. So these are tau deposits of tau fibrils and tangles inside neurons in the neocortex. And there's some other kind of gaps here in the tissues here, but these are neurofibrillary tangles. But this is tau protein. These are the plaques. These plaques, these are stains for beta amyloids. That's where you see this kind of dark brown stain in here. That's beta amyloid, and it's associated with an inflammatory process around it, and degeneration of nerve fibers transiting through the area, and nerve cells if it happens to be in a cortex or a ganglion. So that's what these look like. Now, where are they? Well, neurofibrillary tangles and plaques, they overlap, their distribution overlap, but there are some distinct features. First of all, if we look at anything yellow or red is a lot. And look at the deep red here for neurofibrillary tangles. So there are a lot of tangles in the medial temporal lobe and some of the pole, the front pole of the temporal lobe, but also throughout the temporal lobe. So that's all yellow and red. And it relatively spares the primary sensory area, the primary motor sensory areas of the brain. But if we look at plaques here, the yellow, first of all, there isn't any red here, but the yellow here, so here's the scale from kind of violet to blue, where there's very low, where there are very few plaques or tangles, and a lot moving toward yellow and red. Look at where the plaques are. They're mostly in the, the parietal lobe here, and the occipital lobe and the temporal lobe here. That's where most of them are. And that extends to the medial side of the hemisphere as well. So the distribution, yes, they overlap, but their relative numbers differ between neurofibrillary tangles and plaques. Now, how do we identify Alzheimer's disease in the preclinical phase? Well, one way is to use PET scanning and to image the amyloid and tau proteins in the brain. And I'll show you examples of amyloid deposition anyway in the brain with PET scan. Another one that won't be popular is, because it requires a lumbar puncture, is to measure the proteins, tau and amyloid, within the cerebral spinal fluid. Another key or can be helpful is genetic testing, and I'll talk about that in just a second. And probably the most important thing as a risk factor, an expectation factor, if you like, of Alzheimer's disease is a strong family history, meaning 2 or more members of the family with a history of a dementia of presumed Alzheimer type. Well, genetics is important, and here's one interesting observation. A group of Icelanders was found to possess a rare mutation, which reduces the chance of the precursor to beta amyloid breaking down to form the pathological beta amyloid fibrils. And interestingly enough, Icelanders who carry this protective mutation retain excellent cognition well into their 90s. So genetic influences are important. Well, here's an illustration of just how important. Here's a gene, Apple E gene, which in its aberrant form favors the deposition of beta amyloid, the formation of beta amyloid and the deposition of it within the brain. If there are 2 copies of this ApoE4 gene, meaning both parents contribute to it, then roughly 50% or more of those who are carrying both copies of the gene will probably develop Alzheimer's disease. And if they do develop it, they'll develop it earlier than those without any genetic bias. If they carry one, if there's but one copy of this, then the risk is around 25% of developing Alzheimer's disease. But it's around 5 to 10% if we don't carry that gene. Now, in the case of the autosomal dominantly transmitted Alzheimer's disease, that's much less common, somewhere between 2 and 5% of the population, but on the 2% side. What this means is if you carry this dominantly transmitted gene, you will get the disease, and you'll probably get it a decade or 2 before the usual sporadic form of Alzheimer's disease. At a stage, an earlier stage, where there's less confusion with vascular factors, because vascular factors are usually, they occur later. So that's something I'll return to later. Now, what about the time course of changes in the autosomal dominantly transmitted Alzheimer's disease? This is actually a very interesting model to look at, because these are high-risk patients who carry the gene. You get something that looks pathologically and clinically very much like Alzheimer's disease of the sporadic type, except that it occurs 1 or 2 generations earlier. So now this is a terribly busy slide, but the point is here, the 0 point, the time scale here starts at 0. What is 0? 0 is when a patient, their cognitive function, memory is of such that a diagnosis of dementia, and specifically Alzheimer's disease, can be made based on clinical data. So that's time 0. Then if we look back 10, 20, or 30 years, what was there evidence of that these patients were going to develop Alzheimer's disease, and it's obvious. Just never mind looking at whatever box kind of applies to all of them. Something's going wrong somewhere between 10 and 30 years before the development of Alzheimer's disease in patients with the autosomal dominantly transmitted form. Now, this is really obvious in this, just as an example, illustrates the deposition of A beta, or beta amyloid deposition in autosomal dominant Alzheimer's disease years before expected clinical symptoms. Now, here are carriers of the gene and non-carriers. And 20 years before, they both look entirely normal. They're PET scans. These are PET scans illustrating where beta amyloid is deposited and when. Now, here at the 10 years before the clinical diagnosis was made, there are changes in the brain, and they're pretty obvious changes, illustrating the deposition of beta amyloid. And certainly by the time the clinical diagnosis is made, it's really obvious that the deposition of beta amyloid is obvious. And so that makes the point that with autosomal dominantly transmitted Alzheimer's disease, and probably the sporadic or even familial Alzheimer's disease, the disease begins at least a decade, and probably 2 or 3 decades before any clinical symptoms begin. And in fact, in the case of the dominantly transmitted Alzheimer's disease, it probably began in the brain much earlier, maybe 4 or 5 decades before. After all, the mutant gene was there at conception. So something to think about when it comes to treating this thing. Now, ever since I was trained in neurology, this amyloid hypothesis has been around. It's based on the notion that these obvious deposits of beta amyloid and tau, these abnormal proteins, on the view that these deposits are the primary cause of Alzheimer's disease. They're not just the garbage left over for the kind of cellular debris left over from the disease, but they are the actual agents of the disease. And therefore, if you create a drug that prevents or clears or both this beta amyloid from the brain, then if the hypothesis is true, then it should be possible to demonstrate that if you are on these drugs, and they do show the loss of this cleansing of the brain of beta amyloid, they do demonstrate that there should be, if the hypothesis is correct, there should be a correlative protection or slowing of the progression of cognitive decline in the disease. That's the point of this. So that's the amyloid hypothesis, stated simply, and which has been around for at least 4 decades. Now, what about clinical trial endpoints? Clinical trials are tricky things anyway in most diseases. They're expensive and hard, difficult to mount and sustain, but never more so than in the case of dementia. Because what are you assessing? You're assessing behavioral change and cognitive change. and how reliable and sensitive, how discriminative are those tests of cognitive function in a longitudinal fashion. So if you see a trend, how significant is that trend? And then there are functional studies of mobility, ability to get around, and just activities of daily living. And I would say the gold standard, if not the platinum standard, are serial PET scans, because PET scans reveal the deposition of the beta amyloid, and can also reveal tau. So some more comments about clinical trials in dementia, specifically Alzheimer's disease. They are very expensive, these trials. It's hard to recruit patients. These are long studies that go on over several years. Pharmaceutical companies, it represents a major investment for them, probably reaching into the billions, I would think. Times one of the drugs that we're going to talk about, Antiamyloid, that's been in the works for at least 12 to 14 years from the beginning. That's a huge investment. So pharmaceutical companies, they've invested a lot of money, a lot of time and effort, and some of them become very involved in the design of the trial, study design, the management of the trial, the analysis of the clinical trials, preparing the actual articles for publication in medical journals, as well as in some cases, lobbying regulatory bodies, such as the Food and Drug Administration in the United States, the FDA. So they can be expensive. They involve cooperative participation of both clinicians, regulatory bodies, and pharmaceutical companies, and that can be a tricky relationship. Those could be tricky relationships. And in this case, with Alzheimer's disease, the whole raison d'etre for the study may be based on a flawed working hypothesis, namely that the amyloid hypothesis is right, meaning the positive amyloid causes the disease. So, here's an interesting one. It's very complex. You may or may not be able to see all the details here, but I'll just walk you through this. Beta amyloid has a precursor protein. It's made from a precursor protein called amyloid precursor protein. And if it's a protein, there's a gene that coded for amyloid precursor protein. So a protein, at least a gene to a protein, to the beta amyloid fibrils. That's the sequence here. Here's what that amyloid precursor protein looks like. That the protein is embedded in cell membranes, and it's only part of that protein that is the kind of the represents the problem in Alzheimer's disease, and that happens to be this A beta component, which you can see embedded in a cell membrane here. And what happens is that a mutant form of that beta, if the gene is abnormal, then the protein, the amyloid precursor protein, may be abnormal in that A beta site here. And if the gene is abnormal and the precursor protein is abnormal, and the A beta part of that protein is abnormal, that's where the trouble develops, because in its mutant form, that beta amyloid forms kind of strands that are stick to one another, and forms filaments, fibrils that are insoluble, and forms the plaque, pathological plaque that we were talking about earlier. And here are the sites of action of various types of drugs. So one, its action seems to be quite late here in the process, and others engage earlier in the process. And some of the enzymatic ones act much earlier. Anyway, so that's the kind of the picture, the overall picture of the amyloid precursor protein, the amyloid beta sub part of that protein, and the cascade toward a plaque here in the face of a mutant form of that A beta protein. So that's the train. Well, let's look at the anti-amyloid drugs, 1990s through to this year. The enzyme blocking drugs, they seem to block the synthesis of the mutant form of the beta amyloid, but there was no evidence that they helped cognition, and the same is true with some experimental vaccines to the beta amyloid. They seem to work in some cases, but in this case, with the vaccine, some of them had terrible side effects. And there's a whole family of so-called monoclonal antibody drugs, or MAB, MAB here. And the ones we're going to be talking about is aducanumab. That's the controversial one that was recently approved by the FDA, and an NMAB, which is in development right now. So let's look at aducanumab. There's no doubt. Now, this, as I said earlier, this drug has been in development for at least 12, 14 years, and some of the early evidence, going back to 2016, when the kind of clinical trials, were in process in the early stages, it certainly showed that it could reduce the A beta amyloid deposition in the brains of patients with Alzheimer's disease. And there was some suggestion in the kind of early phase 2 trials that cognitive function, especially in the higher doses of the drug, that the decline in cognitive function might be slow. So that was very promising. The problem came, most drugs fail at the phase 3 level. And this is where you're looking at much larger numbers of patients, hundreds and thousands. And in the aggregate, there were 2 studies, Emerge and Engage, of roughly the same size, but they were independent trials constructed very similarly to evaluate aducanumab in patients with early Alzheimer's disease. That is mild cognitive impairment, or very early in the earliest stage of clinically manifest Alzheimer's disease. Both trials were stopped before their intended end because the data didn't seem to show or didn't show any clinical impact. It certainly showed that the drug was cleared beta amyloid from the brain, for sure, in the PET scan, no doubt about that. But the evidence for clinically significant impact on cognitive dysfunction in Alzheimer's patients was far more controversial. In one of the trials, the other one, it showed no impact on cognition. So that and it provoked a lot of controversy because the FDA, essentially the Federal Drug Administration Bureau in the United States, approved this drug really based on the beta amyloid clearing properties of the drug, not so much on its cognitive, on the evidence that it had an impact on cognition, although much of the discussion seemed to center on that. And they approved it for use in early Alzheimer's disease, but there was an uproar, and it continues to this day. And you can see this reflected in some of the papers here, revisiting FDA approval of aducanumab. That was a perspective or opinion article in the New England Journal of Medicine, and in the same issue, another article, Controversy and Progress in Alzheimer's Disease, FDA approval of aducanumab. I think there was some concern about whether the drug company Biogen was too much involved in this process. I can't comment on that, but they were certainly involved for sure in the process. Now, I think I've touched on some of this, but why reasons drugs, good drugs, maybe even effective drugs, might fail to affect clinical progression in Alzheimer's disease? Well, if there are comorbid conditions such as cerebral vascular disease, where the drug wouldn't be expected to have any impact. The cognitive tests might be too insensitive to identify statistically significant changes. The treatment may have begun too late. And remember that the material I showed you on the autosomal dominantly transmitted form of Alzheimer's disease, where it was very obvious that there were changes going on in the brain at least a decade, 2, and maybe even 3 decades before the clinical diagnosis was made of Alzheimer's disease. So the question is whether a drug that had an iffy record and significantly impacting the decline of cognitive function might not have been shown to be much more effective if these patients had been treated earlier, half a decade, 5 years, 10 years before the clinical diagnosis was made. That's a big if. And there's another question. These studies did not address tau, but tau, remember, that's the protein that's jamming up nerve cells, and probably most related to the memory problems and the kind of GPS-like functions in the temporal lobe. So there are a lot of questions here. So we come to this next one. Are we on the right track with Alzheimer's disease? And the journal Nature, which is one of the best in the world, one of the premier ones, brought this up 3 years ago and raised this question. The amyloid hypothesis on trial. Is amyloid beta the only part of the puzzle? And I think that's, I think personally, looking at the evidence, I think it is. It's only part of the puzzle. Now, there is another drug following on the approval of aducanumab. Here's another one, donanemab. It's now in phase 2 trial, and following the same template as its predecessor, meaning it has shown clear evidence of clearing of beta amyloid from the brain, and suggestive, in single quotation marks, suggestive evidence of a positive impact on cognitive and progressive cognitive impairment. So, the summary here. Well, development of drugs and clinical trials take a long time and they're very expensive. So if aducanumab had been ditched, so to speak, and failed, it probably would have discouraged the whole industry for developing similar drugs. But with its approval, mind you, mixed approval, but its approval by the FDA, then similarly acting drugs, like the most recent one, donanemab, will probably have an easier time securing approval, and other drugs like it. But I think it all gets to the issue: is are we treating these patients? Too late in the course of their disease? This is a fundamental concept because it isn't just Alzheimer's disease. What about Parkinson's disease? What about any of the other neurodegenerative diseases that probably have a long preclinical phase in which if you were going to do anything, that's when you should be doing it. There's another point in here too. So not only should treatment begin earlier than it was here, but it's good to remember that only about 1 in 10 of the participants in the aducanumab trials were positive for PET, meaning there was a gate that the patients had to get through. And only those, the 1 in 10, who were PET positive for beta amyloid, were accepted into the trial. Well, what about the other 80 or 90%? And something I haven't talked about, that there are significant dose-related adverse side effects related to aducanumab, and probably others in the family. And they're related to those side effects or adverse side effects include swelling in the brain and microhemorrhage. Now, this week, last week in September, I have a piece in the Lake Report on this very subject, and just bring up it's an interesting piece because I always look forward to weekly issue of Nature, but in the latest Nature was a piece written by Paul Nurse. Caught my eye, and he quoted a Nobel Prize-winning friend, Sidney Brenner, who stated 20 years ago, "We are drowning in a sea of data and starving for knowledge." Brenner's observation, recycled by Nurse to apply to some science these days, hit home with me, because I think that's been the case for research in Alzheimer's disease. A lot of data and a several-decade fixation on the amyloid hypothesis, which claims that Alzheimer's disease is caused by the accumulation of beta amyloid and possibly tau too. So whether I'm right or not, I don't know. Was the FDA right or wrong? Well, I think they were. The criticism of the FDA is justified because I think the evidence that the drug had a significant effect on slowing cognitive failure was less than impressive, well less impressive, and not there at all in the other phase 3 trial. But in that, they were treating patients for a relatively short period of time in a late stage of the disease. Late, I don't mean late stage. Early Alzheimer's disease clinically right now, but given the fact that it has been evolving already for 1 or 2 or 3 decades beforehand, it's a relatively late stage to be treating this disease. So maybe the drug, maybe the hypothesis is correct, but these patients are simply being treated too late in the course of the disease. Now, just wrap up here. Isn't this a lovely scene of that's Fort Niagara across the Niagara River? I think it's July, and it's a lovely, lovely scene. Here's what it looked like in the winter. I think it's probably early February. It's a beautiful day. There must have been a big H round this time. The skies are clear, except for a few clouds. But look at all that ice built up there. So we're somewhere in between those. So this is a conversation that will continue for sure with the FDA and in our community. I should add one last thing before I close. These treatment with these drugs is very expensive. The estimate with aducanumab is around $50,000 US at least, and that doesn't include all of the expenses. And the total might run up to $60,000 or $70,000 a year. That's a lot of money, given how common Alzheimer's disease is. So that's something to bear in mind. But thank you very much. And the next session is going to be on miracles, meaning unexpected, really good outcomes in medicine, and we'll explore those reasons. So that'll come up in a month. Oh, thank you, and I'm sorry that we've not actually seen one another. I do miss that, but at least we've got the issue out, and you can see or hear what the arguments are. All the best, and hope to see you on YouTube for the next talk. And just remember, final thing, the Nobel series, which begins in early November. That's a 6-week, every week, probably using the same format, but hopefully with same participation from you, as well as with the speaker. So that's something to look forward to. I think the first one is November the 4th, but anyway, I'll have to check on that. But then it follows every week thereafter for 6 weeks. So I look forward to seeing you